Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. I'm going to be talking about the role of transesophageal echocardiography in the structural heart interventions. And we know that the structural heart interventions, the number is increasing internationally, but also in Pakistan, and the number is increasing exponentially. And it's because of the improvements in technology, the procedural techniques, and the imaging. No unit should be doing structural heart interventions without a properly trained imager, and the interventionalist doing these procedures should have the know-how of these procedures as well. There's a big range of structural heart interventions, ranging from ASDs, VSD closures, to TAVI, to mitral clip, to left atrial appendage closures, tricuspid, and so on and so forth. I'll be talking about the mitral clip in detail and its TEE guidance. The rest of them, we can have separate sessions on each one of them. But the important thing is, with ever increasing volume of the structural heart interventions, there's going to be more and more need for the cardiologists, the imagers, to be trained in guiding these procedures, because these procedures are TE guided. They are only fluoro assisted, but they are guided by the transesophageal echocardiography. And I would suggest this comprehensive document to anyone who is interested to have a read of this one, American Society of Echocardiography recommendations for a screening of structural heart interventions in these conditions. Dr. Parveen Akhtar has spoken in detail about TAVI. Transthoracic echocardiography is important. TE might play a role, but the CT is a cornerstone for the TAVI. Left atrial appendage closures, we do them in our center. CT is important in assessment and planning, but again, it's a TEE guided procedure. The procedure guidance is covered to some extent in the mitral clip, so I will be talking about this in detail. I will talk about the mitral regurgitation and the mitral clip procedures. We all know it's one of the most common acquired valvular heart diseases. The treatment is surgical. The mitral clip is only reserved for select few cases. Echo is the most important tool in the assessment of the anatomy, to understand the etiology, assessment of the MR severity, and then its impact on the LV cavity itself, and then guiding for the appropriate therapy. Mitral valve edge-to-edge repair, commonly the most commonly used one is a mitral clip, so I might be referring to a mitral clip again and again. It's used to treat high-risk patients with severe symptomatic functional or degenerative mitral regurgitation, and the idea is to approximate the free edges of the leaflet to make a double orifice mitral valve. Also, now there are variations available as well. So the initial application was more limited to the patients with predominantly central MR, and even now the ideal patient is the one with the A2P2 related mitral regurgitation. Although more recently the technique has been used in other locations as well. So the mitral clip, if we are selecting patients, so there is a specific criteria for selection of these patients, and it is based on the Everest 2 trial. And anyone can have a read of that, but there are a few points that the transesophageal echocardiography will be instrumental in screening and in selection of the patient if they are suitable for the mitral clip therapy or not. Once the transthoracic echocardiography, it indicates that the patient might be a candidate for the mitral clip therapy, then the next step would be a two-dimensional or a real-time 3D echo as well. The pre-procedure TE is very important because it provides a detailed assessment, and it can provide you what you need to be doing on the day of the procedure and what kind of the mitral clip will be needed there. So once we are doing the pre-procedure TEE, there are a few specific views which everyone needs to be aware of. So apart from the assessment is usually done in the bicommissural to explain to the LVUT. So that's where the 3D and the live 3D comes in. So if you have the explain, it makes the life much easier. And I will be showing a few images of the cases that we we did, and you sweep from the lateral to medial to exactly see where the pathology is. Then you go to 3D en face, and we try to put the commissures at the 10 and 2 o'clock, and I'll be talking about that, why that is important. The bicable view with the X plane to the reverse aortic valve is a basic view when we are doing the atrial septal puncture. Then the four-chamber view, we will be doing it. The four-chamber view will be doing it for the height of the puncture at the interatrial septum. So once a patient comes on the day or a day before, we reassess the mitral apparatus. In the mitral apparatus, we do the baseline. We repeat all the images of the baseline again. The important things to note is to look at the left atrium, the left atrial appendage, to exclude any thrombus. And then also we document the presence or absence of the pericardial effusion. So now coming to the actual imaging, so the pre-procedure or on the day of the procedure, we reassess for the exact anatomy, the severity of the mitral regurgitation, and then, as I said earlier, in the bicommissural and then X-plane to the LVUT long axis, we sweep from the medial to the central to the lateral, and it's very clear the pathology here is central. So this is the ideal case, the A2P2 prolapse associated with severe mitral regurgitation. Once we have done that, then we measure the length of the leaflets. We look at the flail gap and the flail depth as well, which all are important in selection of the appropriate therapy. We do the 3D en face at this point. So if you, and that's important because when the imager and the implanter is there in the room, and when they are manipulating the mitral clip in itself, so if the imager says move it towards the 2 o'clock, he knows that's where the commissure is, or move it away from the commissure, then they both know where exactly the mitral clip needs to be placed. So once assessment is done, the next important step is the interatrial septal puncture. The optimum position for that is going to be slightly posterior and superior. So we can see how important it is to have live TE guidance at that point. And it's usually looked at in the short axis view along with the reverse view on the X plane. On the bicable view, we can see the superior vena cava and the inferior vena cava, and I will be showing the videos of that in a bit as well. So these are the basic views for the interatrial septum. In A, we can see the bicable view. Usually the interatrial septal puncture needle, it is brought from the superior vena cava towards the inferior vena cava, and usually we can feel when it falls into the fossa. We want to be away from the aortic valve, and the X-plane will show us exactly where the aortic valve is. So we want to be away from the interior, which will increase the risk of puncture into the aorta. The bottom, the C, is important because we want to know exactly where we are puncturing. So the puncture site in the interatrial septum, it should be at least 4 centimeters from the annular plane. It can be relaxed to 3.5 centimeter if it's a functional MR, but ideally it should be more than 4 centimeter high from the annular plane. So once we identify the tenting on the interatrial septum, then the needle is advanced into the left atrium. A couple of points that the imager will be telling the implanter. The foramen OL should be avoided because of its interior position. If there's an ASD, it should not be used to cross the interatrial septum because then there are problems with stabilizing the delivery sheath within the defect. So this is basically for the interatrial septal puncture. Bicable, X-plane into the reverse 4-chamber view. The cursor should always be at the tenting point because we want it to be away from causing any trouble. This again is showing in our case the height from the annular plane was 5 centimeters, which was more than enough for the procedure to go ahead. Once the wire is there, the wire is directed towards the left upper pulmonary vein, and again, it's not possible without the TE guidance, although you can see it on the fluoro, but the TE is going to be the mainstay of the procedure there. So once we have the delivery system into the LA, we want it to be positioned exactly above the left weight, the mitral valve before it is crossed into the LV. At this point, it can be seen both from the LA and the LV if you have the 3D live echo with you. There are two important views which I wanted to show. So the one main thing is the mitral clip has to be closed when it is closing, when it is crossing the mitral valve. You don't want to be damaging the mitral valve. The two main views for that, again, are going to be the bicommissural view, which is with the X plane into the LVUT view. On the LVUT view, if it is open, you will see the wings, and on the bicommissural view, you wouldn't be able to see the wings of the mitral clip. Once you are crossing it into the LV, again, you want to make sure that it is pointing towards the apex of the LV rather than to the one or the other direction. The one particular issue with the guidance of the TE in this procedure is because it's continuously emitting the ultrasound waves, so the quality of the images, it starts deteriorating, but you have to put up with it. Sometimes you might have to stop the TE. In these cases, again, all the X-plane images you have to keep in view for this to be exactly on the in line. Once it's within the LV, then the implanter is going to put down the gripper so that both the leaflets of the mitral valve are gripped in within the arms and the grippers of the mitral clip. So this is where the 3D en face will come. So the 3D en face, you can see it from the LV and the LA. You need to make sure the commissures are at 10 and 2 o'clock. And then you want to have the proper gripping by the mitral clip there. You also want to make sure that there is no medial or lateral dive, and there is no anterior and posterior dive of the mitral clip before you deploy it. Once you are happy with the grasping of the mitral valve, again, it will be in the 120, which is the LVUT view, in which you will be able to see the grasping of the leaflet. The important part is to create proper cooption, which you can see in the MPR, which you can see in your LVUT and in your bicommissural view. So once the implanter is ready for implanting the mitral clip, there are a few things they will be asking the imager, and that will be the imager job at that point before the release of the mitral clip. So you can understand how important it is for the imager to be aware of these parameters. So there should be good grasp, which is indicated by the leaflets are not moving that much. There's not much slack in the leaflet either. And there should be a formation of a stable anterior-posterior leaflet tissue bridge with a double mitral valve orifice. So over here we can see that the mitral clip has been deployed, which is making a good tissue bridge over there as well. Then we check the mitral valve gradients. The parameters for the mitral regurgitation post-mitral clip, they are not very well established, but there are a few things that we can do to be assessing the mitral regurgitation post the clip. I wouldn't go into the detail of these, but once we are happy, the imager is happy, once the implanter is happy, then the pin can be released. But there's a point that we have to be perfectly sure that we want the implanter to be releasing the pin and deploying the mitral clip fully. So then we assess for any possible complications, pericardial effusions. The important thing is to assess for an ASD, and you should be prepared to close the ASD if it's a significant ASD there. So I know that it's a lot to take in one session, but I think the take-home messages are, apart from the TAVI, which is CT based and CT guided at the moment, all these procedures are going to be TE guided. If it's a mitral clip, if it is going to be tri-clip, if it is going to be the septal ablations. And I think we need to train more and more people in these if you want to have these structural interventions to be available everywhere and anywhere. We are happy to train anyone. We have got the facilities as well, and we will welcome anyone to come and join us for these procedures. Any questions?
Excellent talk. Are you doing mitral clip at your center?
Yes. So we have done two, and we are actually doing two in the coming week. So on the 7th, we are doing two more. I did
That's
quite a
great.
few when I was abroad, so I did about, yeah, about 100. The cost, yeah, the cost is one of the thing at the moment. So the cost is about 1 crore rupees, 1 crore 10 lakh rupees. The some of the centers in our center, we have been lucky enough to negotiate it. So we do a lot of TAVIs as well. So with that, we are able to negotiate the prices. So we brought down the price. But the thing is, if someone wants to have a procedure without a major surgery, we should be able to offer the procedure.
1 crore.
No, the patient has to pay all of it. Yes, yes. So the mitra clip in itself, it's about 90 to 95 lakh rupees. And then you have to have all the sheets and everything, which comes separate. It's not subsidized, no.
Uh, Excuse me. I just want to know that mitre clipping is, as far as the previous literature indicated, is indicated for high risk patients for who have got severe or moderate mitral regurgitation,
Yes.
and those patients who have got a reduced ejection fraction.
Yes.
Because in order to avoid the risk of surgery. In this patient which you showed, I think this patient had a mitral valve prolapse because
Yes.
the LV movements were quite good.
Yes.
So,
Yes.
what is the compelling indication we have to convince the patient that instead of 10 lakhs, it is going
Yes.
to cost? So, please, can you tell?
Yeah. So the first thing was the patient had the prohibitive surgical risk. His STS score was quite high. He had extensively, a very educated patient, this one, extensively looked at in different places. He was actually sent to us from Liverpool. He went to Liverpool for assessment, and he was told that the facility is available there. Why don't you do it locally? So it was a patient choice and prohibitive surgical risk.
But his LV function was quite good.
Yes, but he had the LV had started going down. Actually, we needed to offload him to get him ready for a procedure. So with a severe mitral regurgitation, he was getting decompensated.
Patient's choice.
Yes, yes. I think there's a question. Yes. 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 So majority of these patients will be turned down, so they wouldn't be going for surgery in the future. With these procedures, both with the TAVI and with the mitra clip, we actually see immediate improvement in the parameters. So if you look at their mitral regurgitation, their pulmonary flow would actually improve if you compare it with the basal. This particular patient, he actually walked out of the hospital the next day by himself. We have seen much improvement in his quality of life as well, but we will be publishing the results of these as well. Okay, thank you.